afternoon, everyone. Welcome to our session entitled Dealing with the Cough. Cough is one of the most common symptoms of pulmonary fibrosis and can have significant impact on a patient's quality of life, but it can be really hard to manage. So I'm happy to introduce our speakers for today, Dr. Meena Kalluri and Dr. Kershaw. Dr. Kalluri is Medical Director of the Multidisciplinary Collaborative ILD Clinic in Edmonton, Canada, where her group's clinical and research focus is on symptom management and patient empowerment to improve quality of life in pulmonary fibrosis. And Dr. Kershaw is joining us from Dallas, Texas, where he's part of the UT Southwestern Interstitial Lung Disease Program, which is a member of the Pulmonary Fibrosis Foundation's Care Center Network. Welcome first to Dr. Kalluri, who will discuss mechanisms of cough in pulmonary fibrosis, followed then by Dr. Kershaw, who will discuss treatment approaches and research.
Hello, everyone. My name is Dr. Meena Kalluri, and I'm here today to talk to you about mechanisms of cough in pulmonary fibrosis. We'll start out by outlining the cough reflex and understanding its normal components, followed by identifying causes and mechanisms of cough. And finally, we'll end with listing possible strategies that are based on this understanding of mechanisms. Cough in IPF is quite common. Up to 80% of patients report either dry or productive cough. This is quite impactful. As you can see, there are studies that report on an average, patients can cough anywhere between 5 to 15 times an hour and up to 200 to 500 times a day, causing a significant impact on different aspects of their life, whether it's physical aspects, psychological or social aspects. It also is known to lower survival and is related to more severe disease. Mechanisms are largely unknown, but there are several suspected causes that we will be discussing today. And on account of less treatments, care of cough is generally poor in clinical practice. Now we can think about cough as a complex neurobiological behavior, which is largely characterized by a short, explosive expulsion of air from the lungs, which in that mechanism carries away particulate matter, noxious things from your airways and sends it out of your body. Normally, cough is thought of as a protective reflex, which means it's there to protect your airways from harmful stuff, from aspirated materials, from dust, smoke. But in rare occasions, this normal reflex becomes abnormal. And that's when it becomes more harmful because it impacts quality of life and on occasions is also responsible for spreading infections. Now we think about cough occurring in stages. The first stage starts with inspiration, which is a preparatory stage where you fill your lungs with air. The next stage is compression, where you can see the upper airway is closed off, it's pinched off. And now the rest of the muscles around the chest, the diaphragm and the belly start to contract. And as they contract, they start to generate increasing pressures inside the lungs. And the next phase happens when the upper airway or the glottis is suddenly open, and this air that's under tremendous pressure is then released forcefully through your mouth. And in that process, it clears away whatever stuff was inside your airways, ridding your airways of that problem. So cough is mostly triggered when receptors, which are generously distributed throughout the nose, the throat, the lungs, even the esophagus and stomach. When these receptors are stimulated by different types of stimuli, they could be chemicals. So for example, if you breathe in noxious gases, it could be something mechanical like mucus in your lungs or food that gets aspirated or water that gets into your lung, or it could be thermal. So when you're in situations where you're exposed to cold air or air of different temperatures, sometimes even hot air. So all of these stimuli will trigger your receptors, and these receptors then send that information onto the cough center in the brain through sensory nerves, in this case, the vagus nerve. And once it's received in the brain, the cough center is typically located in the hindbrain or the brainstem. And it also receives input from the cortex or the higher parts of the brain or the forebrain. And this processing lets the brain now recognize that there is a problem in the lungs, and the brain then sends instructions through efferent nerves or motor nerves to the various muscles, which then contract, resulting in cough. And this is what we refer to as the cough reflex pathway. So one part of the pathway is called the afferent, which is right here on the left-hand side of the screen. And the second path is called the efferent or motor pathway, which is on the right-hand side of the screen. Now, cough becomes problematic when this reflux transitions from being normal to abnormal. So what does that mean? Generally, when cough is triggered, it clears the airway, gets rid of the problems, and it resolves. So that's a normal cough reflex. In certain situations, individuals develop what's called cough hypersensitivity. And in that situation, the cough doesn't go away and becomes what we call chronic cough. Now, this chronic cough is persistent, it's unrelenting, and this is what essentially causes most harm. Now, we know in clinical practice that when we look for causes behind this cough hypersensitivity, in up to 50% of cases, we may not find a cause to explain it. So cough hypersensitivity or cough hypersensitivity syndrome is typically characterized by cough that occurs at low-level stimuli, meaning things such as laughing or taking a deep breath, which normally should not trigger a cough, triggers a cough in this case. And we think that happens because the sensory pathway that we just talked about, which is the pathway on this side of the screen, gets activated. It gets sensitized, resulting in an enhanced cough reflex. This happens in IPF, and there is some evidence to suggest that. We know that IPF or pulmonary fibrosis is characterized by traction bronchiectasis or scarring in the lung, honeycombing, and even MUC5B mutations, which result in increased mucus deposition. And all of this distorts the lung or irritates the inside of the airways, which then triggers these receptors. And I mention these receptors simply because this might be useful in the future as more specific blockers are developed. So these receptors, when they get triggered, they send information through these nerve fibers and up the vagus nerve and into the brain. But in the presence of architectural distortion of the lung, we believe that these receptors somehow become hypersensitive. They might get overstimulated, they might increase the number, leading to an enhanced cough reflex. So proof for this comes from the study where chest percussion was applied to patients who have IPF and patients who don't. And what the study showed was that low frequency vibrations ranging from 20 to 60 hertz produced more cough in IPF patients than in normal patients. And interestingly enough, more patients coughed when their posterior aspects of the lungs were stimulated. This is where there's more fibrosis. So this suggests that mechanical effects from the scarring in the lung are probably leading to cough. Another factor that causes increased cough hypersensitivity is the presence of these chemicals called nerve growth factors, which trigger these neurons to behave differently, become more sensitive, the receptors get more sensitive, and this is why the cough reflex is enhanced. So this is a second pathway of increasing hypersensitivity. We also know that there is normally, under normal conditions, normal physiological conditions, cough inhibition and cough stimulation are generally balanced. But in fibrosis, because there is destruction of the inhibiting nerves, there is overstimulation, and this imbalance can also lead to cough hypersensitivity. Recent years, there's been increasing interest in the role of mast cells in the etiology of cough. So mast cells are basically these cells which are generally found, or if they're living in the lining, inner lining of the lungs, and they get stimulated. When they get stimulated, they release chemicals, lots of different mediators, and in particular, something called histamine. And this histamine sensitizes these nerve fibers we talked about, and this can lower the cough threshold. We also know that in IPF patients, their sputum contains, or their BAL contains, higher levels of histamine when compared to non-smokers or other controls. So this might be another mechanism to explain cough in PF. In addition, we also know that cortical influences can evoke cough in PF. There are several centers in the brain that get stimulated when you have an urge to cough. And this was studied through functional imaging of the brain. As you can see on the left-hand side of the figure, there are numerous areas of the brain outside of just the brainstem that get stimulated when you cough. And the panel figure on the right-hand side demonstrates how cognitive processing in the brain allows you to cough when you feel an urge. Sometimes it allows you to suppress a cough, and in other situations, you can cough voluntarily, in addition to coughing automatically, which is called a reflex cough. So all of these different responses occur because we believe that the brain plays a huge role in regulating and processing cough, and that might represent an important target. Now, capsaicin challenge test is something that provides us further evidence of cough hypersensitivity in IPF. Now, capsaicin is an extract of red peppers and is frequently used in clinical research to induce cough. And in this study, when they gave capsaicin to patients who have IPF and controls, each time, whether you looked at 2 cough response or 5, IPF patients tended to cough at lower levels, suggesting that there is an increased cough hypersensitivity. Now, in addition to cough hypersensitivity syndrome as a mechanism, we know that PF patients can cough from a variety of other causes or conditions. Now, in this study, 21 ILD patients who were seen in the chronic cough clinic were examined, and in about 50% of them, other causes were found. So what are these other causes? They're commonly referred to as the 3 Rs: rhinosinusitis, reactive airways or asthma, and reflux diseases. So these are the 3 Rs that are commonly associated with cough and should always be looked for in patients who have cough in a variety of different types of PF. In addition, medications such as ACE inhibitors, certain diabetic medications can cause cough. Smoking, other pulmonary diseases are frequent causes as well. Now, we also know that comorbidities play an important role in generating cough in PF. And 2 particular comorbidities, such as the reflux disease and obstructive sleep apnea, which are quite common in IPF, can themselves produce cough. So as you can see in this figure, GERD results in cough, and the mechanism is thought to be stimulation of this cough reflex. Similarly, sleep apnea can cause cough, and we think it is mostly because of increased cough sensitivity. And you'll also note that each of these conditions, IPF, GERD, and OSA, they also promote each other. So there is a complex interaction between these conditions, and assessing for them and managing them will be very important in cough management in this condition. In addition to GERD and OSA, COPD and lung cancer have also been associated with cough in IPF. More recently, there's been emerging interest around the role of hypoxemia and cough. In this particular study, they used O2 in fibrotic lung disease patients and found that the use of O2 improved quality of life, and this came predominantly through decrease of symptoms. Other studies also suggest that cough is associated when oxygen levels, and it actually improves or sometimes even resolves when you use oxygen appropriately. So IPF or PF-related cough, most important mechanism appears to be cough hypersensitivity that is triggered by mechanical effects, chemical stimulation of these cough receptors. In addition, we think hypoxemia can play a role, although the mechanism is not clear at this time. Comorbidities, other causes, in particular the 3 Rs, medication use, along with smoking and air pollution and there may be several other mechanisms that are yet not discovered. Now, clinical treatment strategies always align with understanding of the underlying mechanism. So if we want to list possible strategies for cough in PF, one of the first things that should come up is management of this cough hypersensitivity. There are numerous strategies, both pharmaceutical and non-pharmaceutical, that have been shown to affect cough hypersensitivity. In particular, speech language therapy or behavioral therapies can be effective. Neuromodulators, these are medications that can block these peripheral receptors that can affect the functioning of these sensory nerves that carry information from the receptors to the brain, and also the brain centers themselves. So you can have peripheral as well as central neuromodulation through these drugs. Of course, managing the underlying condition, whether you use antifibrotics or anti-inflammatory medications or mucolytics, they might help. In addition, blocking these chemical mediators, particularly the nerve growth factors, perhaps the mast cell and other mediators involved might be another useful strategy. We know that oxygen supplementation may help. Actively identifying comorbidities and managing them appropriately based on guidelines is another strategy. Smoking cessation and environmental hygiene, methods to improve air quality. And there's ongoing research to look at other possible etiologies and therapies. Now, to summarize, cough is common and troublesome in PF. Mechanisms are multiple and complex. We think that cough hypersensitivity syndrome, which is a new paradigm to explain chronic cough, is a possible explanation in PF. This is characterized by cough that is triggered by low-level stimuli, which is generally not supposed to invoke coughing. Upregulation of sensory afferent pathway. The evidence for this is plentiful in PF. In addition, it's important to remember that other causes of fibrosis can be active in pulmonary fibrosis as well, and therefore it's important to look for the presence of other comorbidities and other causes. This is why a systematic approach to assessment is required, and further work is needed to come up with more effective evidence-based therapies in order to improve quality of life of our patients and caregivers. Thank you for your attention.
Hello, my name is Corey Kershaw. I am an associate professor of medicine at UT Southwestern Medical Center in Dallas at the interstitial lung disease program at UT Southwestern. And today I'm going to be talking to you about dealing with your cough and specifically the past and current research on measurement of cough and treatment. So how do we assess cough in the real world? There's lots of ways that we assess cough in research studies, but I think you'll find during the course of this presentation, measuring cough outside of a research trial can be challenging. Here's some questionnaires that I put together to show you some of the things if you've never been in a research study of cough, you'd be asked to do. One way that we measure cough in research studies is with the Leicester Cough Questionnaire. It's a 19-item tool that assesses the physical, psychological, and social quality of life with chronic cough. This is not specific for IPF or interstitial lung diseases, but most of the studies that we do of some therapeutic intervention of IPF where cough is an outcome, this is a really good example of a questionnaire used frequently. And I'll just read one of the questions. In the last 2 weeks, have you had chest or stomach pains as a result of your cough? And you'll see it's a Likert scale. All the time, most of the time, a good bit of the time, some of the time, a little of the time, hardly any of the time, or none of the time. And this is given a score. And how that score changes over time is how we assess the effectiveness of the intervention on the patient's cough. Here's another one that has pretty common use in research studies, the cough-specific quality of life questionnaire, the CQ-LQ. This is a bit longer. It's a 28-item list, and you get scores for either agreeing or disagreeing how cough affects the patient across 6 subscales. And it's important, as with any of these questionnaires, that when the patient's given them, that they're given very specific instructions that they have to answer the questions as relates to their cough. So as you can imagine, in an IPF study, it may be a little tough to separate shortness of breath in affecting the question versus cough. So the patients are given very specific instructions, and these are self-administered. So you're not sitting in a room with someone asking you the questions, you do them yourself. So once again, question number 1, family and/or close friends can't tolerate it anymore. That being the cough, agree or disagree, and so on or so forth as you go down the 28-item questionnaire. Here's something we use to measure cough that actually may be useful in the clinical setting. This is called a cough visual analog scale, or VAS. These are used very commonly in research studies, but it's very, very easy to do. The patient sits down with a piece of paper that has this drawing on it, and they basically put an X along the line of where they think their cough is rated. So it's like asking someone, how bad is your cough on a scale from 1 to 10, but it's done visually where they look and decide where to put their X. And depending on how their cough changes, that X will move up and down visit to visit. This is something that very easily can be done in a clinical setting. Your doctor walks in, says hello, asks how your cough is doing, and hands you the piece of paper. And then you mark the X, and then we measure it. And you can record that in your clinical chart visit to visit that, last month the patient's cough was at 55 millimeters, but after our intervention a month later, it's now at 25 millimeters. That's significant. A lot of clinical research studies that use the cough visual analog scale in studies, usually anything above 40 is considered significant for cough. So this is all great. These are subjective things, but what we really need is something that can objectively measure cough. I know how this is affecting you, but how much are you actually coughing? Well, the best way to do this is with recording devices. And in fact, there are several of these available in research studies, and I have a couple of the more common ones here. This is the Leicester Cough Monitor in Leicester, England. They do a lot of cough research, as you can tell. The LCM, there's a picture of it here. It's a lightweight system. The patients wear this portable digital recording device, and they have a free-field lapel microphone. I've also seen this as a necklace microphone, and it records continuously the patient's cough, and then the data is downloaded and analyzed using an automated algorithm, and this algorithm is capable of detecting cough specifically and can also reject non-cough noises. So it's really good at filtering. As you can see, I wrote here, it's very accurate in picking up coughs and really good at ignoring non-cough sounds, because if you get a lot of noise in the background, it's not going to be very helpful. And this is another one that is very, very common in research studies, the Vitalo Jack. This is also a lapel microphone, but it also has a contact microphone on the upper chest. And you can see in the photograph here from their website, the patient has the microphone actually attached to their chest. It's another ambulatory recording device. It's worn in a little belt bag that you can see there. It has a really nice software algorithm that compresses the audio recording, so it takes out all the silence and the noise, because unlike the LCM, this actually has a person sitting down and doing the analysis. So someone who's experienced listens to the compressed recordings and then uses an audio visual display to score the recording essentially. This is, as I said, this is a very commonly used device in clinical trials, and I'll show you guys a few trials that are up and coming where this was the device they used to measure cough. Because it doesn't use an automated algorithm, it's going to be subject to human error and scoring. So, a little bit of a problem there, but these are the two really newer one and more commonly used cough monitors in research studies today. So what does the future look like for cough monitoring? Well, we really are trying to find a way to move these cough recorders from research studies to more practical use in outpatient clinics. This is all great if you're in a study, but most of our patients are not in research studies of cough. And how do people like me, your doctors, decide how bad is your cough and what we need to do about it? We really need way to objectively measure that in the clinic. Everyone carries a smartphone, and a lot of us have these home electronic speakers like Alexa. So there must be some way to leverage that technology to measure cough. And in fact, there's a lot of work in this area. There's several apps in development. There was one that a few years ago that was actually published some papers about. I haven't heard much about it since, but sort of be on the lookout for that this may be coming someday, where some really smart engineers may figure out our smartphones to record our cough for our doctors, much like these, people who have smart watches that can measure their heart rate and detect if they have an arrhythmia. We should be able to use this technology for cough. And in fact, people are trying to figure that out. So what about some of the future therapies? If you listen to my previous talk about some of the current treatments for cough, you'll know that there's things that have been tried, but not a lot of things specifically for chronic cough. But this is a bright future, frankly. This is a busy, sciencey looking slide, so I apologize if that's a little too much. But I wanted to point out some of the things in the two green boxes you see, one at the top of the slide and one at the bottom. These are the names of some nerve receptors. The CNS targets, these are ones that are actually in the brain and spinal cord. P2X3 is a receptor you'll hear about a lot if you do any reading on your own about some of the new cough therapies. And you'll notice that P2X3 is also in the airways themselves. So this is an important connection that may have a role in stimulating cough. And then NK1 is another one that I marked here just because of some of the medications I'm going to talk to you about. So here's some future therapies that could be in the road ahead of us, hopefully soon. These are not really for ILD yet. These have been tested more in chronic cough itself, but as with anything, if it starts to work for chronic cough, then we can start looking at it for some other things. The first one of these is aprepitant. Aprepitant is an NK1 receptor blocker. That was one of the little nerve receptors I X'd in the previous slide. The nice thing about aprepitant is that it's already available. This is an improved medication that's used for nausea and chemotherapy. And at least in one trial, it showed a benefit in the cough associated with lung cancer after taking it for only 3 days. So that shows a lot of promise. There's no trials in ILD yet, and I did a search before the presentation, and there's still no one's doing that, but that could be in the future for us. There's a couple of P2X3 receptor blockers that are really close to getting approved. The first one is gefapixant. There's been a couple of studies of gefapixant. Gefapixant's a little non-specific for binding the P2X3 receptor. You notice it binds this other receptor as well. And in many of the studies for chronic cough, they're pretty specific about excluding people that may have some other cause for their cough. So it's really right now geared toward patients who just have a chronic cough for no clear reason. In 2020, there was a phase 2A study published, and then some data from 2 phase 3 studies were presented at an international meeting in 2020. The great thing about this medication is that it's been pretty consistent in significantly reducing chronic cough after about 12 weeks of therapy. It's a dose escalation, 50 milligrams twice per day has been the dose that has seemed to be most effective for chronic cough. The problem with gefapixant is that the higher the dose goes, you start to have more side effects, and the big side effect is something called dysgeusia. Dysgeusia is a word that many of you may have seen before because it's an alteration in taste. And in the world we live with COVID now, this is a common thing that COVID causes. So dysgeusia, this is another problem that could happen with a drug like gefapixant. In fact, in one of the trials that has been presented to the FDA at the top effective dose, it was almost half the patients had some change in their taste. So that may be a problem. We'll see. The FDA has had, this actually was submitted for a new drug application in March of 2021, and the FDA has accepted that application and it's still under review. So stay tuned for that. There's been at least one study in IPF that I'm aware of that was small, 44 patients, just published this year, that itself did not show a benefit, but small study, stay tuned for that. A competitor drug to gefapixant is eliapixant. This is a selective P2X3 receptor blocker. Once again, their trials have excluded patients with restriction on PFTs, so that may leave some of our IPF patients out at least now. A phase 2A study that was successful was published earlier this year, and just a few weeks ago in September, the company released a phase 2B trial that seemed to be also successful. So they're gearing up to submit to the FDA as well for approval for chronic cough. And once again, if these are approved for chronic cough from unclear causes, you can sure bet that someone's going to really look at patients with IPF or other interstitial lung diseases really hard for these medications. One other drug to keep an eye on is this drug, nalbuphine. This is Nubain. It's a medication used in pain medicine for moderate to severe pain. There's a trial ongoing right now. It's still at the very early stages in the UK only, and they're enrolling patients with IPF and cough for more than 8 weeks. So in summary, right now we have cough questionnaires and cough monitors used primarily in the research setting to measure cough. But there are emerging technologies from smartphones and smart speakers that may lead to more practical use clinically. And new medications are coming for chronic cough. And hopefully this will lead to more trials for cough, specifically in ILD in the near future. Dealing with your cough, and specifically the current treatment approaches to cough as it pertains to idiopathic pulmonary fibrosis. So why is it important to address cough in patients with IPF? Well, first of all, cough is very common. It affects up to 85% of patients, depending on how cough is defined in the studies. If you either define cough as an occasional cough or disabling cough, any form of cough, 85% of patients complain of that. It's more frequent during the day. It has no relationship to age or gender. It becomes more common as the disease advances, and oddly, it's actually worse in the patients who have never smoked. And it's not uncommon at all for the presenting symptom of the patient's IPF to be cough. In fact, it may precede the presentation of IPF by as much as 18 months. This can be a significant source of distress for patients as well as care providers, as I'm sure many of you know. These are some quotes that from an FDA study that was sort of a patient and caregiver panel getting information about what mattered to patients and care providers in terms of drug development. What was important to you? And so these are some quotes from that publication. This is the wife of a patient. He sounds like, quote, "Something is caught in his throat. It's like he's unable to finish one cough." A husband speaking about his wife. "Over a period of years, eventually she, quote, couldn't catch her breath. She couldn't stop coughing. I'm afraid that after some of his coughing fits, he's just going to stop breathing. If I could just get this phlegm out, I would be fine." I'm certain many of these phrases are familiar to all of you. So when we approach the treatment of cough, we have to ask ourselves what seems like a simple question, but is a very important question. Why am I coughing? Is it because of IPF, or is it something else? And it's very tempting to laser focus in on IPF as the cause, but in reality, there may be something else causing it. And if we don't address those other causes, we're not going to be able to help you. So this is an approach to cough treatment that we should all take as providers with patients. 5 steps. Step number 1, to eliminate any potential triggers of cough. As I said, your cough may not be from your IPF. Step 2, manage any medical problems associated with IPF. Step 3, treat the common causes of chronic cough that are not IPF specific. Once again, if we just focus on IPF as the cause, we're going to miss other potential causes of cough. Step 4, here we are, manage the IPF or the ILD itself. And then step 5, manage the cough directly. So you'll notice in these 5 steps, we don't really talk about managing cough itself until step 5. So we have to do everything else first to be sure we're not missing other causes. Step 1, we have to eliminate any potential triggers of your cough. This could be external triggers such as secondhand smoke in your environment or any environmental allergens. If you're someone who's prone to seasonal allergies, wintertime, springtime, it could be related to your cough. And so it's important to control those. There's a class of high blood pressure medications known as ACE inhibitors. These are very common. These are medications like lisinopril. A frequent side effect of that medication is a cough. So if you're taking an ACE inhibitor, it may be as simple as just changing you to a different antihypertensive instead of, once again, being focused on IPF as the cause. Step 2, we have to manage medical problems associated with the IPF. It could be that some of these associated problems are either contributing to cough, causing the cough, or exacerbating the cough. Gastroesophageal reflux disease, or quote, acid reflux. The way this could relate to your cough is you could be aspirating the acid reflux or the reflux into the esophagus itself instead of into your airway. That could stimulate a cough. We have cough nerve receptors throughout our esophagus and the airway. Hitting any of those could cause a cough. And then just to continue the cycle that we're in, the cough itself could weaken the closure muscle at the end of the esophagus that leads into the stomach. This could then worsen reflux, make your cough worse, which then worsens the reflux, and then we're in this cycle that we can't get out of. Obstructive sleep apnea, not uncommon at all in patients with IPF. And in fact, either untreated or even undertreated sleep apnea may increase the sensitivity of the cough, making it more easy for you to cough if you have some other trigger or the IPF itself. So it's really important that if you have sleep apnea, you have it treated. If you think your sleep apnea is not as treated as it should be, maybe something has happened with your weight, the mask doesn't fit as well, it's important to get that checked out by your physician to ensure that you're still being treated appropriately. There's an associated condition with some interstitial lung diseases called pulmonary hypertension. This is high blood pressure in the lung circulation itself. If you're prone to fluid retention because of pulmonary hypertension, this could be a trigger for cough as well. Step 3. Treat the common causes of chronic cough. These are not IPF specific. In fact, the American College of Chest Physicians in 2018 published this guideline known as the Treatment of Interstitial Lung Disease Associated Cough. And their recommendation in this guideline was that for patients with ILD and refractory chronic cough, we suggest trials of therapies recommended for patients with unexplained chronic cough. So nothing specific about ILD, just also treating the same chronic cough that other patients get. So what are these common causes? Well, we approach these common causes with something known as a diagnostic trial of treatment. So what this means is it may be hard for us to diagnose one of these problems as a cause of your cough with testing. So we actually give you a trial of treatment. And if your cough responds to that treatment, that's a backdoor way of reaching the diagnosis. These three most common causes of chronic cough are asthma that mostly leads to cough. We also refer to this as cough variant asthma, upper airway sourced cough or postnasal drip associated cough, and then our old friend gastroesophageal reflux disease or acid reflux. So it may be that even though acid reflux could be triggering your cough, your cough could all be from acid reflux possibly, because it is in fact very common. So we'll get at these one at a time. So what do we do about if we think asthma is the cause? Well, we can try some things such as inhaled steroids. And I've listed some examples here of medications: fluticasone inhalers, budesonide inhalers, beclomethasone inhalers. There's many of these out there. As needed bronchodilators could be tried. This is what albuterol is. And even montelukast. This is Singulair. There's at least one small study that showed that patients who had chronic cough due to cough variant asthma responded very nicely to montelukast. So what the doctor would do is we would try one of these things, as I said up at the top of the slide, at least 2 to 4 weeks. These are not things that are going to work in just a few days. You really need to give it at least a few weeks, if not a little bit longer, to see if your cough is going to respond to that diagnostic trial. The next most common source, postnasal drip cough or upper airway sourced cough. These are things such as allergic rhinitis, non-allergic rhinitis, chronic sinusitis. Any of those could be a source of cough. If you're someone who seems to feel like something is dripping down the back of your throat, that could be the stimulus. So what do you try there? Nasal steroids, fluticasone, which is also an airway inhaler. It comes as a nasal inhaler too. The memetazone nasal steroid. Once again, a few weeks or even up to 3 months of a trial should be done to ensure that this is not what the problem is. If the problem is not so much in your sinuses, we think the problem may be in your throat, the back of your throat. The treatment of choice really is first generation antihistamines. These are things like chlorpheniramine or brompheniramine, with or without a decongestant. Decongestants are pseudoephedrine or phenylephrine. You'll notice it doesn't have anything in here about other antihistamines like loratadine, fexofenadine, or cetirizine. So those are brand name. That's Claritin, Allegra, Zyrtec. Because unless it's very clearly due to allergies, the effect that actually affects the effect you get from the medication that improves the drippiness, if you will, is much better with the first generation antihistamines than the other ones. There's nasal antihistamines, azelastine is one of those, and then nasal ipratropium. So lots of options here to try in case we think the source could be from upper airway. And then finally, acid reflux associated cough. The first approach should be lifestyle modifications, not eating 2 to 3 hours before your bedtime, raising the head of your bed at least 3 to 4 inches, avoiding culprit foods. This should be simple, but we all do it. These are acidic foods. Chocolate and alcohol are probably the common sources of causing acid reflux from foods. Stopping smoking, if you're still a smoker, this can exacerbate acid reflux. And then if lifestyle modifications alone aren't effective, a trial of a proton pump inhibitor. These are medicines like omeprazole, esomeprazole, at a moderate dose for at least 8 weeks, 2 months. And I have an example here. If omeprazole is the drug of choice, 40 milligrams per day for at least 8 weeks. If we don't think acid reflux is suspected, or we do some extra testing with a gastroenterologist that shows there is no evidence of acid reflux, these medications should be stopped because they're probably not going to be helpful. Next, we turn to actually managing the IPF itself. So what about the role of antifibrotic medications, nintedanib, pirfenidone? Their role here is not very clear today. Neither the Impulses trial, which led to the FDA approval of nintedanib, or the Ascend trial, which was the last phase 3 study for pirfenidone, neither of those trials measured cough as an outcome in their 2014 publication. So at least based on those papers, we don't really know what the effect on cough would be. But there have been 2 separate studies of pirfenidone. One was 2011 before FDA approved pirfenidone, and then one more recently in 2017, which I have some of that data here. This was 43 patients that were started on pirfenidone and also had moderate cough for at least 8 weeks. And the patients had significant improvement in their cough counts and a subjective cough score at 12 weeks. I'll talk more about some of these measurements of cough in the next talk. So it's just something to consider. We don't know about nintedanib. Pirfenidone might help cough. So if we're struggling with the right antifibrotic for you and cough is a dominant factor in your clinical presentation, that may be the way to go. And then step 5. So here we are, managing the cough directly. We've done all these things up to this point. Now let's focus on the cough itself. There's been 4 therapeutic trials that I'm aware of that were published specifically targeting the cough in IPF. These were trials of steroids, maybe a benefit at 4 weeks of steroids at a pretty moderate dose of 40 to 60 milligrams per day. The downside of this, I'm sure many of you are aware, long-term steroids just have a lot of side effects, and it can complicate a little bit of your IPF treatment because we know that some of the medications that lower the immune system actually may be a little harmful in IPF, so we have to really pick our spot there. There was one trial of thalidomide. Thalidomide is a medicine used for nausea decades ago, but the nausea of pregnancy decades ago, but was pulled off the market because it was toxic to the fetus. But it does have some interesting qualities that may make it effective for cough. So here's a study that was published with 24 patients that took thalidomide for 12 weeks, and they reported that their quality of life was significantly improved by taking thalidomide for their cough. The problems with thalidomide, it has a lot of side effects. Dizziness is very common. It can cause some constipation as well, but dizziness is really the big side effect of thalidomide. There's some challenges of prescribing because of its toxicity to pregnant women. There's some barriers that doctors have to overcome to actually prescribe the medicine. And for a lot of providers, it's a little onerous to even take those steps. And only 20% of the subjects that the investigators screened for the trial actually completed the study, again, because of side effects. That 2018 guideline that I showed everyone a few slides ago, they did not endorse thalidomide for chronic cough. It was favored by many of the people on the panel, but it did not reach their threshold to give a recommendation for thalidomide for chronic cough of IPF. Inhaled chromoglycate. This is a medication that's very similar to cromolyn, something we use for nasal allergies. In at least one study, it decreased daytime cough frequency. This was a phase 2A study that was published in 2017. So we were very excited about the idea of using this inhaled version of chromoglycate. It comes with a very special inhaler that the manufacturer developed. There was a phase 2B study that was started, but it ran into the COVID pandemic, unfortunately, and that trial was terminated early, I assume, for some recruitment problems related to the pandemic. Omeprazole has also been studied. This is back to our old friend with gastroesophageal reflux disease. This was focused specifically on cough in IPF. The study suggested there might be a benefit, but they had a lot of trouble recruiting patients for this study, mostly because the patients had to be off their proton pump inhibitor or acid reflux medicine before they went into the study. And the investigators just had a little trouble finding patients willing to do that. So what are some other options we have? Well, there's some things that aren't exactly related to the cough and IPF, but these are just some options. There's gabapentin, that's also known as Neurontin, that we use to treat neuropathy. There's some data that behavioral therapy by speech-language pathologists may be beneficial. Pregabalin, that's also known as Lyrica, plus the speech therapy was shown beneficial in an escalating dose trial up to 14 weeks. Case reports of baclofen and amitriptyline also may be of benefit. Common cough medicines such as benzonatate, that's Tessalon pearls, dextromethorphan have really no decent supporting evidence. Opiates are recommended when basically all else has failed in treating the cough. This is just my personal take on this. This is opinion only, no evidence to support this. It's just what I tend to do in my practice. First level options, scheduled benzonatate, 200 milligrams 3 times per day, scheduled dextromethorphan, 30 milligrams 3 times per day together. This may not work, but the downside is quite low from a side effect perspective. I then go to the next level, trying one of those other medications we mentioned, gabapentin, baclofen, pregabalin, cyclobenzaprine, that's a muscle relaxant I've had some success with before. Slow up titration to guard against side effects. Third level, if that doesn't work, try one of the other ones, switch it around a little bit. You may have some benefit. We could consider adding a codeine-containing elixir for bedtime if cough is bothersome with sleep, and considering a referral to speech therapy to help with some suppression techniques, as we talked in the previous slide. I thank everyone for their attention. I just want to leave this slide up here for everyone to look at it. This is the stepwise approach to cough treatment we've gone through in the last 15 minutes here. And thank you again for your attention.
Hi, everybody. Okay, well, those were incredibly informative talks. And Now we're going to have a little question and answer and conversation. We've had a lot of really great questions come in from our audience. So I'm excited to hear from our experts here, Dr. Kalluri and Dr. Kershaw. Thank you guys for being here with me and for talking with us about this really important topic. So I'm just going to dive into a couple of our questions, and we'll have a little conversation. Dr. Kershaw, first I'll ask you, since you talked a bit about treatment, we have a question about gabapentin and it being helpful in controlling cough for some people. What is the position on this in the sort of ILD community and your approach?
There are a few little small things out there about gabapentin. I will tell you my own personal take on this, and a lot of this that we're going to talk about for the next 15 minutes or so is a little bit of personal experience. I'm sure Dr. Kalluri would share her personal experience too with managing cough. It's like baking a cake a little bit. Sometimes you have to add a little bit of this and a little bit of that since there's not a lot of great research about this. Gabapentin is in my tier of help after sort of the routine things that are less side effect causing, like benzonatate, Tessalon, and just simple over-the-counter dextromethorphan. I tend to rotate a little bit between gabapentin, baclofen, and cyclobenzaprine. Those are sort of my three go-to drugs. I don't think the community at large would say, oh, gabapentin is the one to use, but there are individual providers that like to do that. And anecdotally, I've had people that has worked very well for. There's this dose escalation study that looked at IPF patients with cough, and you had to push the dose up to the least effective dose without causing side effects. A lot of these medicines can make you feel dizzy, you're a little detached, you're sleepy, and so you have to be careful between balancing side effects and any potential benefit. And so that might be one of the reasons why these are not always well accepted. I would say I think people get a little nervous about creating a new problem, but cough is debilitating. And so I kind of approach this that I'm willing to try different things in individual patients to see what works. That's
great. Yeah. Dr. Kalluri, I have a question for you about maybe the relationship. I hear a lot about not cough per se, but throat clearing. And are those two things related?
Thanks, Dr. Case. So yes, the urge to cough is being quite frequently described by patients, not just with IPF-related cough, but also chronic cough. And we believe that the urge to cough is part of this cough hypersensitivity syndrome, and it represents a overdrive of these cough mechanisms, whether it's the peripheral part of the pathway that we talked about or the central path. And these pathways, for some reason, are hyperactive. So a lot of these patients, whether they have IPF-related cough or other PF, or even chronic cough that's not associated with either one of these conditions, they frequently describe that there's this constant urge to cough, constantly trying to clear your throat. And again, I think I really like Dr. Kershaw's approach. You go down that methodical approach, you start working your way up from the top, and you want to make sure that there aren't other reasons why you're constantly trying to clear your throat, because it can also happen with asthma. It can happen with reflux. So all of these conditions need to be looked at, need to be resolved if possible. And then if you're left with nothing, then you have to sort of conclude that this is part of your chronic hypersensitivity syndrome. So this is frequently described and is quite common in chronic cough. And there are different approaches which can start with trying to figure out what is actually causing it to begin with.
That's a great answer. Thank you. So Dr. Kalluri, I have another one for you, and maybe Dr. Kershaw, you can weigh in as well. I hear a lot about, and this is something that's coming up in our questions, I'm not just asking my own questions, a lot about coughing spells or paroxysms of cough. And it's, people can cough throughout the day, but they have these spells where they're can't stop, and it feels like it's going to go on forever. And I feel like cough medicines, once that started, by the time it starts working, that's sort of already gone. And so the question here is, are there any kind of tricks of the trade, I think, that can help abort those paroxysms of cough once they've started, to sort of quiet that feedback loop, sort of?
That's a very, very excellent question, but unfortunately one that we all struggle with in daily clinical practice because we don't have enough experience or strategies that have been studied. But having said that, I know that there are several techniques within the speech language therapy world, within the respiratory world, that sometimes can help abort this. So for example, most of this cough tends to be related to a hypersensitivity syndrome. So this urge to cough, that's what it appears triggers some of these episodes. Sometimes it's a few bursts of cough, sometimes it's just one or two and it settles. So if you are able to recognize this urge to cough when it arrives, or when you start to feel it at the back of your throat, and then you can apply some of these techniques, such as effortful swallowing or becoming mindful or conscious about it. There are certain tricks and tips that the speech language therapists often teach some of our patients when we're lucky enough to engage one. So I would say that's one approach. This would be a non-pharmacological approach. The other approach, of course, sometimes the cough could be related to oxygen issues. So if your oxygen is low, or you're finding that your oxygen levels in the blood is low while you're active, while you're talking, that could be an approach to check and see if you can increase the flow and find relief. The other approach that I've seen works for some of my patients, especially when they complain of these coughing spells triggered through conversations, is to actually try and break the sentences into smaller bits and pieces and take breaks and be able to breathe in between. So it's a combination of recognition and having certain tips and tricks through your therapist, and following oxygen. And then of course, have a conversation with your physician. Sometimes there are other approaches which can act fast, like opiates and things like that. But that's getting very, very personalized.
Thank you. Dr. Kershaw, I have one for you. Switching a little in the gears to some of the research that you talked about. Any thoughts on or ideas about the rationale? I know you weren't necessarily involved in the planning of these studies, but any thoughts on the rationale for excluding ILD or chronic lung disease patients from the chronic cough studies? You mentioned that they really aren't being included at this time, but might in the future be studied.
I think, again, not to put thoughts into people's heads about why they do certain things, but I think probably part of the problem is, there's a little bit of that helplessness for patients who don't know why they're coughing. And so, as I said in one of my presentations, you really want to get at the cause of the cough first before targeting the cough itself. These are patients that don't have that, because, in spite of, usually seeing multiple physicians, multiple pieces of testing, they never find a cause for it. So they have really nowhere to go. And so it's a large population of people. And we're looking at those patients that we can't really treat anything else but treat the cough itself. When you start bringing in other factors into play, like there's a clear cause for it, and that cause may not be well controlled, there's a little bit of research technique that comes into that, because you want to have as pure of a patient population as you can. And if you've got your patient population that's sort of mixed in with a group of patients with very different causes for their cough, it's hard to tell whether the intervention that you're testing was really the reason that the patient got better and not for some other reason, or the opposite. They didn't get better because some of the patients, their underlying cause was not addressed. So a little bit of it has to do with just proper research trial design. A future study, though, could really look at very specific IPF patients, but you would have to have a population that are as homogeneous as possible, that look the same as possible, to be sure that whether it's gefapixant or one of these other drugs I mentioned actually is what helped the patient. So we want to be sure that whatever research we do and whatever conclusions we reach actually are helpful. They're actually meaningful to the patient. And I think with something like cough, as we've sort of heard with multiple presentations this hour, there's many different reasons that you could be coughing. And if we're just treating the cough itself, we may be missing something.
Very good. Thank you. Dr. Kalluri, I have one more for you, and we're running a little low on time. We've got so many great questions from our audience today. I wish I could get to them all, but this next one is about, it kind of goes to mechanism actually, and has to do with either continued or cessation of cough after lung transplant. And do people still cough after their transplants, or does that stop?
So once again, excellent question. And I think once we begin to understand what cough hypersensitivity is a little bit more with PF and IPF, we may be able to explain that better. We know that a lot of patients do resolve because once their lung condition is taken away, you get a new set of lungs, they do have an improvement in their symptoms. But over time, some of these patients start to develop cough. And once again, you have to go down that pathway of figuring out, is this cough, what is this cough from? Is this really related to the underlying condition? Is this a new thing that's developing? Is it a side effect of some of the other medications that you're taking? So it really requires a systematic approach. So, but in general, we would think that if it is related to the local causes from having fibrosis, well, that part is taken care of when you get a transplant. But if you remember, we talked about that pathway having a peripheral as well as a central part of the pathway. So when you get a lung transplant, you hopefully take care of some of those peripheral receptors in the lung, but not necessarily all the nerves. Some of the nerves may not always be repaired appropriately or get back to their normal function. And then, of course, there's the central part. We're not doing anything to the brain or the central mechanism of cough sensing. So if for some reason, if you have fibrosis and those pathways are active, we wouldn't not necessarily think that they would get reversed or get better with transplant. And we don't necessarily truly understand that. So that might be one of the reasons why it might persist even after transplant.
Excellent, thank you. We have like 1 minute left. Dr. Kershaw, do you want to give us a quick thought on the use of prednisone, either in the acute or chronic setting for cough?
Sure. And I think I did also see one of the questions about like after an upper respiratory tract infection, something like that. So I think that's pretty well established that sometimes people, they'll get over a respiratory tract infection, everything kind of gets better except the cough lingers. And there's certainly a role for prednisone in one of these post-viral tussive syndromes. I think that when you've run the list of things and you've tried so many things and nothing helps, and there may be a little something that makes you feel like that there could be some excessive airways inflammation that's so vague, I realize, but you have to kind of take a little bit of the patient's history. I'm not opposed to perhaps some short trial of prednisone, but boy, you're really starting to go down a slippery slope because what's the end point? And some of these drugs like benzonatate may be effective for some people and really doesn't have a whole lot of downside to it. Prednisone has a huge downside. And I think this only comes into play when you're kind of entering into a palliation phase of care. And now I've got someone that I'm really gearing my focus a little more towards symptom management as opposed to disease management. We do those in parallel, but whenever the symptom management part starts to take a little more precedence, I think that's where sort of prednisone comes into play. And then we can accept some of those long-term side effects for symptomatic relief of the patient.
Very good point. Thank you both for being here. We are out of time, but this has been a wonderful discussion, some really great information today. So I hope you've all gotten a lot out of this talk, and thank you both for being here. I just want to remind everybody to come to our fireside chat with Pulmonary Fibrosis Foundation President and CEO Bill Schmidt and our PFF medical team, including me, in Theater 2 in 30 minutes. And we'll also be joined by legendary Yankee all-star musician Bernie Williams. So thanks everybody, and see you soon.